within 3 millimeters superior from the normal center and 5 millimeters medial. We've seen in our research on the offset and the leg length that this gives us very predictable and restorative leg length and offset. And we also know that fixation remains better within these numbers. There's data in the literature quite clearly on the level of fixation related to the level of the center of rotation. Hartophilikitis in 1993 published an article that says if your center of rotation was more than 2 millimeters, 3 millimeters superior, and that was on regular x-rays, then their fixation at 18 years was significantly worse. I had an article with Dr. Ranawat when I was in New York that showed that the fixation in protrusio acetabuli was much worse if the center of rotation was medialized or superior by more than 5 millimeters. The Mayo Clinic, an article with Pagnano as the first author, shows that fixation is worse if the fixation and limp are worse in a CDH hip if the cup is superior. So for longevity of the hip, comfort of the hip, the center of rotation is really the most important technical maneuver we do. And why? Well, because you keep the joint reaction forces the best in the hip, you keep the muscle resting tensions correct, and you keep the flexibility of the hip the best, and so that's comfort for the patient. And this is the x-ray we would all like to see every time. We've got the cup in the correct position, we've got the center of rotation reestablished, and we've got good leg length and offset, all of which is possible. How do we get that center of rotation correct every time? Well, when we're doing it manually, we have just as much scatter as we do for finding inclination and anteversion. But we're really quite good at it with the robot. You can see here that we're within that 3 millimeter vertical is how much superior. We're within 3 millimeters on that. And for the horizontal, which is medial lateral, we're less than 5 millimeters on the mean for that. And really our standard deviation is not that high. So we're really quite good at getting the center of rotation back within the numbers we want compared to the pre-op x-ray of that patient. If we look at the center of rotation compared to the normal contralateral, which we were able to do in a good number of our hips, then you can see we still keep it within 3 millimeters vertical. We keep it within 5 millimeters horizontal. You can see that in the right-hand column where it lists difference. But we have a bigger range when comparing it to the true normal rather than just what the pre-op center of rotation in the arthritic acetabulum was. And so that means that we do have some outliers beyond those numbers if we compare it to the true normal. And those outliers were about 18%. So we kept our center of rotation within in just over 80% within the true level. And those hips are obviously going to do the best. They're going to do the best for longevity. They're going to do the best for comfort. And the longevity is because their fixation is going to be the best. But we're not always able to keep the center of rotation within our normal. And we saw that within the study. The hips, where the center of rotation wasn't within 3 millimeters superior and 5 millimeters medial to the normal, were hips that had dysplasia and hips that had significant deformity of the acetabulum. So we can look at this x-ray of the dysplastic hip and see that it's superior and it's medial. And it's a very good cup position for this patient. It's got a good fixation. But when you move the center of rotation superiorly more than 5 millimeters or more, as was shown in data from Bourne, Rohrbeck and Bourne, you have to use an offset stem because otherwise you can't reproduce the offset and you can't get the length of the gluteus medius back. So you can see we used an offset Zweimüller stem in this patient to be able to restore that offset and balance the leg length and the offset. Now, the same thing's true in an eroded acetabulum. This is significantly eroded. The femoral head, the patient waited so long for an operation that the femoral head was significantly migrated and the acetabulum was eroded, so the cup ends up superior. And in these types of cups, you usually need screws for fixation if you don't normally do it. I normally don't do it, but these cups are not contained within the acetabulum as stably, with as much stability, so that we do have to use screws. And again, you see it's an offset stem. That's the only way to keep your gluteus medius length correct and to balance your leg length and your offset. So the center of rotation we can do very well, except in these more deformed hips, but otherwise we do it very well in the using the robot, better than we can where there's manual performance of preparation of the acetabulum, because as I already said, that has at least a 6.5 millimeter possible error. So my time's about up, and I would again like to thank you so very much for the opportunity to present what I've learned and why I think there's benefit in using machines in the operating room. We have to improve our human performance. If you're not willing or don't want to use a machine, why then you're just going to have to really work on it. Practice does make perfect. I showed how my estimation of my femur improved with practice. My acetabulum's even improved. I really manually can get the acetabulum 90% of the time within where I want it. But there are those patients who have tilt of the pelvis more than 10 degrees that you just can't know that without either preoperative x-rays. You can take the preoperative sitting and standing x-ray like I showed you and get an idea of the very flexible person. And you can get an idea of the tilt, of course, with a machine because it measures it. And the literature definitely proves the need that we get things right. We need to get the components right. We need to get the center of rotation right. And we don't need long-term outcomes to prove that point. We've already got data from previous studies that have proved that point. So it isn't like we need to do these operations and wait 10 years or 20 years to show we're better. We know we're going to be better because the data has already been there to tell us that. In summary, I need to just make my point that I can more accurately perform a hip with computer navigation, and that the robot gives an added benefit of getting the center of rotation correct more commonly, and it adds the added benefit of having a fail-safe mechanism for the reaming and preparation and for the implantation of the cup. I operate with both machines today. I still use computer navigation. I use robot, and I think that any surgeon that decides they want to improve their personal human performance should try working with these machines, get over the early learning curve, and I believe it will give you a great feeling of benefit once you realize that time and again, almost every operation, you've accomplished your goal. So I just want to thank you again. Thank you very much for allowing me to present my lessons I've learned over the last 10 years and how I personally have improved my performance. And I really want to thank the British Orthopedic Association for allowing me to participate in this conference and by this medium. Thank you very much.